Well, I'm going to introduce myself to everybody. Nice to be here virtually with you all. My name is Nilika Singhal. I'm one of our pediatric epilepsy docs at UCSF, and I'm delighted to get to be here today. And on behalf of our group, I wanted to thank you to the organizers for inviting me to share this presentation with you all. And I will share my slide. I will share my screen in just a moment. Let me get that ready to go. And let's see. Awesome. Let me also sign off of email so that won't bother us in the background. Okay. All right. Well, I'm going to be talking with you this morning about the pathway to epilepsy surgery at UCSF. I have nothing to disclose. Our outline for the morning in the next 30 minutes, we'll be able to talk about why, when, and who for epilepsy surgery. We'll go through pre-surgical evaluation for kids and adults living with epilepsy and what goes into surgical decision-making. So this is a topic near and dear to my heart. As a pediatric epileptologist, these are questions that we face every day, and I'm hoping that we can go through the thought process of when this comes up for me as a clinician, when this comes up for many of our families, and the decision-making process between when to go forward for epilepsy surgery and who all this affects. So we'll talk through the scope of the problem, and hopefully this will provide some guidance and education surrounding this topic. So in general, who is a surgery candidate, I guess is the first question. We know that more than 3 million people in the US live with epilepsy, and many of them, more than a third of people living with epilepsy, continue to have disabling seizures in spite of medication. In terms of the evaluation for epilepsy surgery, we consider someone, I start to think about this when I'm taking care of somebody living with epilepsy for whom the seizures are what we call refractory. That means that the seizures are not well controlled despite being treated with at least 2 anti-seizure medications, or ASMs for short. And so as you can tell already, this is really not viewed as a last resort for me, but rather what else can we do to help this individual living with seizures, which are difficult to treat. And again, we view that as only 2 medications having tried and not succeeded. A little bit of an evaluation, I've listed some of the steps that we take to think about epilepsy surgery, which oftentimes starts with our epilepsy monitoring unit or our seizure monitoring unit. This is when we'll have people admitted to the hospital for us in a planned way to actually try to record their seizures on an EEG. We use these seizure monitoring unit admissions to figure out, is it seizures or is it something else? And if it is seizures, are they what we call focal versus generalized? And so we'll talk about that as well in a moment. And then I've listed the next steps that we'll go through over the course of this presentation: the imaging steps, neuropsychological testing, and finally culminating in our epilepsy surgery consensus conference for presentation and discussion. So we kind of start at, as I mentioned, with this point of are the seizures focal versus generalized? And that really refers to a pattern on the EEG, but just to highlight what that's talking about, here we have a cross section of the brain. So if you could imagine your brain is like a loaf of bread and you're taking slices just as you would a loaf of bread. This is one of these slices. So you're looking at this coronal view of the brain with the top representing the top of the head and the bottom of the slide representing the top of the spinal cord. This is just a schematic of what a focal seizure looks like. We know that the physiology is that a group of neurons, a group of brain cells in one region start to have a seizure, which then can spread as illustrated by the arrows. And when we see a pattern on the scalp EEG recording, where there's just a group of electrodes in a neighboring region or in a similar region demonstrating the seizure pattern, then we can tell that it's a focal seizure. As compared to generalized. So this other view gives us a sense of when a seizure seems to affect all of the brain electrodes all at the same time, then that's what we kind of describe as a generalized seizure. And there can be instances when we actually see both, where we see in this third cartoon a focal seizure, which then spreads and involves secondary generalization. So there can be a seizure which starts in one region and then involves other circuitry to be represented on all of the electrodes together. But knowing whether a seizure pattern is focal versus generalized can help an epilepsy doctor think about what sorts of not only medications, but other treatments could be possible for that individual, including epilepsy surgery. So this is a EEG picture of what a partial or otherwise known as focal seizure can look like. Those two terms are synonymous, where we have all of these electrodes from top to bottom across the page, but the abnormalities are starting in just a few together, versus a generalized onset seizure affects all of the electrodes all at the same time. So that question we think we can get a good handle of during the course of a seizure monitoring unit or epilepsy monitoring unit admission. So after our admission, which we use to capture the seizures, a couple more points about that. If somebody is having seizures daily, then the chance of us being able to catch them during an admission for seizure monitoring is pretty high. There are folks who have seizures less often, like once a week or less, a couple of times a month. And sometimes when those children and adults are admitted to our seizure monitoring unit, we'll actually try to bring their seizures out by gently and safely in a controlled fashion, withholding medications or reducing medications a bit in a way to try to bring out their seizures to expedite the admission for them, but not in a dangerous way that promotes status epilepticus or some seizure emergency from happening. So we'll make those decisions together with our families about how to try to get the data that we need in a way that's safe and monitored for the individual. So after the epilepsy monitoring unit, the next step will be imaging. And so we tend to start with MRI, which I'll talk to you about, as well as other types of structural, as well as what we call functional imaging. So as many.
There's not many people on this first. There's 5, and there's 2 of them, and 3 are theirs.
I'm just hearing some background noise. I'm going to ask for whoever's unmuted to please mute. Unless you've got a question, then be delighted to help with that. But otherwise, if you could mute, that would be great.
UCLA people on there. That's not good.
I'm just going to text in the chat, so please mute your microphone so that I can continue the presentation. All right, I'm just going to continue on, even though there's a lot of background noise. So
Christy, is there something I can help you with?
Oh, I'm sorry.
Yes.
Let me send an email because I'm just getting a lot of background noise from I think it's from the Epilepsy Awareness Day staff.
Okay, can you put your email address in the chat and I'll forward it over to you?
I'm not exactly sure how.
Okay, I'm just going to wait until they mute.
If you registered for the entire expo.
Okay, so you can just pop it.
Yeah, so you'll see it in the email I send over to you right now that there's separate schedules and Zoom links attached to those schedules.
Okay.
Okay.
Perfect. I really appreciate it.
Yeah, I'm sending it over to you right now.
Perfect. Thank you so much.
You're welcome.
Okay.
Bye.
I'm curious if the staff can hear me.
Yes. Yeah, plug in my headphones last night.
Oh, you use like wireless?
Yeah. Oh. Take this with it. Is that not what you meant? No, this is perfect. I was just looking at this computer to see if they were done. Keep track of it. Thank you. This is perfect. All I ever needed is
Is what, an iPhone?
an iPhone charger.
Oh, they charge in the case?
Mm-hmm.
Oh, they go per
Hello? Hi. Oh, I'm sorry. Okay, let me see. I see.
Okay, so sorry about that. I think we can continue now that they've muted their camera, or their microphone. So just to back up a little bit, we would, after our epilepsy monitoring unit gives us a sense of whether the seizures are focal versus generalized, we look at brain imaging, and that will help us to localize where in the brain the seizures are coming from. There are a variety of what we call structural versus functional imaging. And here for structural imaging, we're going to focus our talk with the time that we have on MRI. And we'll talk about some functional imaging that we use frequently at UCSF to evaluate children and adults for epilepsy surgery, including PET, ICTL, SPECT, and MSI or MEG. And so we'll go through each of those modalities in the next few slides. So we use advanced epilepsy MRI techniques at UCSF to help better identify where in the brain an area of abnormality may be, and to help us understand if that person may be eligible for epilepsy surgery or not. So as you can see on the left, this is a conventional MRI. Again, with our loaf of bread analogy, this is the same view, which we call coronal. So it's a kind of vertical slice of imaging. And then what we are able to do at UCSF is really more high level, high resolution scan to get much more precision about what the brain structure can look like. And on the picture on the right, I'll draw your attention to this area in the red circle. So with our advanced epilepsy imaging techniques, what we can identify is the radiographic appearance of parts of brain which can be abnormal on pathology. So when we look at that tissue under a microscope, we can identify what is different about those cells that can promote the onset of seizures that could be treated surgically. And so with our more advanced imaging at UCSF, we can identify areas such as in the red circle, which can sometimes look more blurred or more thickened, or have other characteristic imaging findings that lead us down the pathway to know that this person can really benefit from surgery. Of course, the problem is trying to find a needle in a haystack. And so sometimes people living with epilepsy might have focal seizures that we identify on scalp EEG, but despite our advanced imaging, their imaging doesn't seem to indicate where exactly the issue is coming from. And so our functional imaging can help us in this arena. One of the types of functional imaging that we employ is called magnetoencephalography, or MEG. And a couple of sentences about this. We might remember from physics that every electrical current also generates a magnetic dipole according to the right-hand rule. And so on the left here, we have an example of a screenshot of our EEG, which looks at the electrical activity of brain cells or neurons. And on the right-hand side, we have what a screenshot representation of what a MEG or MEG might look like. And so for every electrical current, we're also going to be able to detect the magnetic dipole which that current is generating. And what can be really helpful about MEG is that MEG gives really high spatial and temporal resolution and isn't impacted by some of the things which impact our scalp electrode ability to detect electrical currents. So that things like artifacts caused by muscle activity, like on an EEG, muscle can really impact our ability to see the electrical waveforms underneath coming from the brain. Scalp EEG is also limited by our skin, our bone, our dura, our hair, all the other physical barriers can sometimes make it much more difficult to find the electrical activity originating from the brain. And MEG dipoles are not limited in that same fashion. So we get higher resolution, higher spatial and temporal resolution, oftentimes by trying to find MEG spikes compared to scalp EEG. And here we can also see that those dipoles can be co-localized on an MRI to give us a two-dimensional representation of really in 2D where in the brain those electrical impulses are originating from. And we can use our MRI in 3 different modalities: in our sagittal, our coronal and our axial views to kind of triangulate where those spikes are originating from. So MEG is an extremely powerful, high yield functional test that can supplement the epilepsy surgery evaluation. Another functional test that we use at UCSF is called FDG PET. And so here, what is happening is that we use a radio-labeled glucose or sugar molecule. And so the person living with epilepsy would actually have an IV placed and injected with saline or with water, liquid containing this labeled glucose molecule. And in the brain, where there is an area of brain that is more prone towards producing seizures, that area will have a difference in its metabolism all the time. And so a PET scan might pick up areas of focal or really localized hypometabolism, which correspond to an area that is more epileptogenic, to that area of tissue that's more prone towards causing seizures. And so what you can see here is it's another way of kind of get that location, that localization of which area of brain could be the hot spot or the culprit behind causing seizures. And so these two modalities that we just went through, MEG as well as PET, are both what we call interictal, which means just baseline or in between seizures. But the third kind of functional imaging test that we like using at UCSF to help us with figuring out the needle in the haystack is called ictal SPECT. And so what we're able to do, and to back up again, this type of functional test is the only ictal study that we have in terms of non-invasively understanding where seizures can be coming from an imaging perspective. And so what an ictal SPECT looks like is that we'll have children and adults scheduled to be admitted to our epilepsy monitoring unit to record their seizures. And at the time that a seizure is produced, we'll actually use a radio-labeled tracer to inject into their IV. And we try to do that within a few seconds of the seizure onset. And because that area is more metabolically active, that area will preferentially pick up that tracer. And so then later that day, the person can get this imaging obtained, and we'll take that data and co-register it on top of MRI to get these really robust pictures of the hotspot itself. And the moment that a seizure is produced can tell us exactly where in the brain that seizure is coming from, and can really provide a lot of help even before the person enters the OR to really plan out their surgery, and can help us to understand possible risks and degree of benefit to be expected for that individual. So these types of imaging, MRI, as well as the functional studies, which we've talked about, MEG, PET, and SPECT, are part of our pre-surgical evaluation to help get a sense of what are the possible risks and benefit to this person, and how do we counsel them about whether we think it would be helpful to undergo surgery or not, and what are the trade-offs for that individual. So far in our talk, we've talked about who are candidates, people living with refractory epilepsy. We've talked through epilepsy monitoring unit, logistics. We've talked about functional and structural imaging, so our MRI as well as functional imaging. And then next will be neuropsychological testing, which is an integral part of our epilepsy surgery evaluation. So children and adults living with epilepsy, we do recommend neuropsychological testing for, and this provides a preoperative baseline of their cognitive functioning, of all the different domains of cognition that are really not able to be determined from just a picture or an imaging study alone, but really how is that person's brain functioning. It can also help us predict any cognitive risk that can happen because of epilepsy surgery. So it can help us get a sense of if this person undergoes surgery, what could be the balancing measures or the trade-offs, if any. This typically involves an array of different types of testing that our neuropsychologists will do with people in clinic or on Zoom. And includes information such as language localization, such as understanding which part of the brain we think language originates from. We go through verbal and visual memory localization to really understand that person's memory centers of where they live. Same for visuospatial function. We can get a good sense of someone's attention and executive functioning. Of course, IQ, which is a battery of tests to understand IQ or other cognitive measures. And then our neuropsychologists help us a great deal with understanding the psychiatric perspective. If there are coexisting mood problems in that individual, And it helps us to understand their expectations, their concerns, their ideas for epilepsy surgery, what sorts of social support, instability, and coping measures are at play before and undertaking such a big deal as going through with brain surgery. And once we've collected all that information from the epilepsy monitoring unit, from our imaging, both structural and functional, as well as our neuropsychological testing, we take all that data and we have a twice a month at UCSF Epilepsy Surgery Consensus Conference discussion. This truly is one of, I think, the strongest bits of that goes into pre-surgical planning, is to really get the group's collective experience, collective opinion, and to go through each individual person's story with detail and with time, so that we don't leave any stone unturned, and to really think through all the pros and cons, and to come up with a very cultivated, individualized approach to that person for their surgical planning. And so at our consensus conference discussion, we have all of our pediatric epileptologists, such as myself and my 4 colleagues, our fellows, our colleagues in adult epilepsy, as well as their fellows, as well as the neuropsychologists, our radiologists to go through imaging with us, and of course, our neurosurgeons for their perspective. And each person's story is discussed, as well as the data that we've collected on them from the epilepsy monitoring unit and from all the imaging and from the neuropsychological testing, to kind of put it together and then give a sense of what sort of surgical approach makes the most sense for that person. That really helps us to counsel people on what to expect, on if this is a good fit for them, and to help individuals think through the pros and cons of surgery. After that consensus conference discussion, we take that data and meet with our patients on that one-to-one basis once again, to go through that presentation information and to relay the consensus opinion for them. And so after this, we talk through whether a surgical approach such as resection, which is removal of tissue, makes sense. But now we have many other modalities offered. So I wanted to talk a little bit about some of the other types of options available for people. If a resection is not an option for a number of reasons, then we can think about other types of ways to treat somebody surgically, including the following: responsive neurostimulation, or RNS, deep brain stimulation, or DBS, and vagal nerve stimulation, which many of you may be familiar with, or VNS for short. So I'll go through a couple of them in our remaining few minutes together. So whenever we're considering epilepsy surgery, we try to come up with an actual map for that individual, where their motor centers live, sensory, language, and where the seizure focus is. And the best case scenario is when the seizure focus, whatever is causing the seizures, is separate from these other really important areas of brain functioning, such as movement, the way that we can sense, and our language. But sometimes we're in a situation where the seizure focus, the area causing seizures, overlaps with some areas that are also doing something really critically important, that person really shouldn't be able to live without, or wouldn't want to take that risk of damaging. And so that's when some of these other modalities come into play. So our RNS target population are people whose seizure focus lies within what we call eloquent cortex, which are these areas of brain responsible for really critical functions that aren't represented elsewhere, such as motor or movement, such as language, such as vision, and such as sensation. RNS can also be beneficial for people who have more than one seizure focus, or more than one foci. And so if there are 2 separate areas of brain tissue producing seizures, where a 2 resection situation wouldn't make sense for that person, then RNS might be an option for them. RNS is also useful for people who have had resections previously that didn't work, that don't want to go through a resection, or that might have, or might provide an intermediate option, especially if the yield of a resection may not be as high as the possible risks to that person. That kind of gives us another option to try to treat them surgically. Just some schematics of what the NeuroPace RNS device looks like, and an outline of the system. And so you can see on the top picture how big this battery and generator pack looks relative to a dime or a pencil. And this is actually surgically placed flush to the skull. And so the whole system is enclosed in a way that wouldn't be obvious to a passerby. Though that battery pack is connected with wires to our electrical leads, which can either be strips or depths that go within the brain tissue itself and are plugged in right to the battery pack. And from there, this can communicate with a remote monitor, with a programmer such as your epilepsy doctor. And also this data gets inputted into the patient data management system, or PDMS, which lives in the cloud. So basically it's a way to store EEG information in the long term, and then take that EEG information and program the device on how to pick up it, how to detect it, and how to stimulate that seizure with electrical impulses to try to stop the seizure within milliseconds, ideally, before it can take hold and spread to other areas of brain. So it provides a really exciting way for using technology to basically learn that individual seizure type, and in time, not only stop that seizure from happening, but we hope would modulate brain activity in the long run to reduce seizures from even being generated in the first place. Another modality that we use is called deep brain stimulation, or DBS for short. This technology has existed for a long time, and it's been applied in other neurological conditions such as movement disorders, like we see with Parkinson's, and other movement disorders, but we're applying this technology to be used in epilepsy as well. And so the DBS system can also uses electrodes, which are surgically placed to a deeper brain target, in the hopes of interrupting this feedback loop of seizures, and so also with time modulating and reducing seizure burden. So this can be an option where people may have multiple foci, or even for generalized patterns such as seen in Lennox-Gastaut syndrome or other more network conditions. And so I think we're on the tip of the iceberg at really understanding the full applications of using RNS and DBS, especially in children. But at UCSF, our center's collective experience with using these is terrific in the state of California and beyond. And so we're excited to offer these more cutting edge technologies to children and adults living with epilepsy to try to treat their seizures in a smarter way. So in summary, we use multiple modalities to determine who might be a surgical candidate. And truly, we view this not as a last resort decision at all. And many of our families who've gone through this process view the day of surgery as truly the first day of the rest of that child's life, which is really a beautiful thing to see. Surgical decision-making involves the values of the person and family living with epilepsy, as well as features of their epilepsy that we've talked about. And those features can be defined by EEG, but also the other modalities that we touched on, including structural imaging such as MRI, functional imaging such as MEG, PET, and SPECT. And surgical treatments are not limited to resection or not, but we also have a variety of stimulators and other neuromodulatory devices that we're excited to share with people living with epilepsy in the hopes of improving quality of life. Thank you guys so much for your attention, and thank you for bearing with us with our audio mishaps, and I hope you enjoy the rest of your conference. And thank you again to the staff and the host for letting me have this time to share with you guys today. Have a great rest of your day.